Hello and welcome to financialexpress.com. I'm Sushmita Panda. The prevalence of cancer is increasing in India. According to the Indian Council of Medical Research and National Cancer Registry Program, the number of cancer cases in the country is projected to go up from 14.6 lakhs in 2022 to 15.7 lakhs in 2025. To talk more about the prevalence of this disease in India, its advancements, today we have with us Dr. Harit Chaturvedi, Chairman, Max Institute of Cancer Care. Dr. Chaturvedi, welcome to Financial Express.
Thank you, Sushmita, for having me. Thank you.
So to begin with, how exactly cancer occurs in a human body and when to know that it's time to see a doctor?
Okay. So it's a very big question, actually, how it happens. So basically, the etiology of cancer is linked with that an ordinary human cell in some ways becomes superhuman, or it becomes immortal, or it tries to grow endlessly. Normally, a healthy cell would stop growing at some point, but this can grow endlessly. And also, this has a potential to seed in some other organ of the body and multiply there as well. For example, a breast cancer cell, if you take it and put it in liver, it will die. But if you put a breast cancer cell, it will survive there also. So these are the two unique properties. Now, what happens that a cell gets triggered into this process is something which is understood to a great extent, but not in all situations. So I would give you a couple of examples at what happens. For example, tobacco users, they are more prone for lung cancer, oral cancer, pharyngeal cancer, even small incidence of breast cancer is because of tobacco, bladder cancer. So a chemical carcinogen keeps attacking or stimulating the epithelial tract, and that repeated stimulus at some point converts into a rapid acceleration, and that leads to growth. Likewise, for example, we talk of alcohol, so tobacco, alcohol, or a good example would be a human papilloma virus. A viral infection in cervical cancer is known that it is the causative factor. It is the causative factor for cervical cancer. But because of the usage of vaccine and good hygiene and a lot of better practices, the cervical cancer incidence has gone down. There again, the mechanism was very similar. The infection, persistent infection, the body's immune mechanism trying to correct it, overcome it, repeated stimulus with the infection. At some point, that trigger goes beyond control and the cells start multiplying endlessly. So, in almost likewise, if I can give an example of a sharp tooth in the oral cavity, that also repeated injury or bad hygiene in the oral cavity, that also leads to which anywhere you have a repeated stimulus in the lining of the oral cavity, gut, or any place which is causing repeated injury can convert into a stimulus. There may be a genetic predisposition. For example, certain cancers we know that it is runs in families, for example. So that incidence is only 5%. For example, a BRCA gene positive has a higher probability of getting a breast or ovarian cancer in those who are BRCA positive. And as I said, this is only 5%. So it's not that it's a big number, but if it is there, then there's a genetic predisposition or there's a genetic exposure probability that if you're exposed to certain factors, the protective mechanism will not work. So these are all reasons which we know. And there's a good chunk of things which we don't know. So we just accept that we don't know. But I can say that almost 65% of cancer is lifestyle cancer. So if we are able to avoid tobacco, alcohol, if we are able to control our weight, for example, weight also predisposes to certain cancers. The estrogen exposure which happens, the estrogen formation which happens in the peripheral fat of the body, that also creates a milieu where there's a higher chances of growth in breast, in uterus, in colon, and certain other parts. So lifestyle has a huge role, and that is why it's very important when I said that these are also very important things for us, because this message has to go out. Exercise, eating habits. For example, red meat is known to be predisposing to certain cancers. So all these things are there.
Dr. Chaturvedi, where exactly India currently stands with respect to diagnosis, care, and treatment of cancer?
So where India stands in terms of, if we look at the diagnosis, for example, even today, almost 65-70% of cancer is diagnosed in stages 3 and 4. Okay, whereas in the developed countries where people have regular screening or a better healthcare system, probably this number is just the reverse, that almost 80% get diagnosed in early stages and 20% advanced stages. So if I look at, there are three categories I will put the cancers. One is the um, one which can be prevented. For example, we know of, I talked about lifestyle cancers, tobacco, alcohol, weight, fat content in the diet, lack of exercise. These things are one component. The second component is a screenable cancers. For example, breast cancer, cervical cancer, oral cancer. These are cancers which can be actually picked up. They have a longish period of before the diagnosis can be made, and therefore it can be screened and picked up early. Then there are certain cancers which can be early detection is possible. So in those areas, for example, lung cancer, in a smoker population, low dose CT scan is a good screening tool and we can pick up lung cancer early. Today, almost 90% of lung cancer presents in stage 4 or stage 3, advanced 3, where hardly very poor outcomes. So if I have to put India on the map of where we stand in terms of diagnosis, I would say we have a lot of distance to cover. And that is only possible if we create diagnostic centers, if we create facilities, a continuous campaign with general practitioners, with the public at large, to understand what is screening, why it should be done, what are the screenable things. All those things are important. Then, if I look at the treatment facilities, I think we have come a long way, especially in the last 20 years. And today, I can say that in all metros, in almost all tier 1 cities, and a lot of tier 2 cities also, the infrastructure is growing very fast. We've got trained manpower. So things are happening, but maybe there's room to improve in terms of quality of care. So care has gone up a bit, but quality still we need to catch up a lot, and that is linked with the processes, the finances, the regular training protocols, the engagement, and good decision making. So, for example, we always talk about tumor boards. A good decision making in oncology practice is tumor board is crucial, or a multidisciplinary team discussion is crucial, where a pathologist, radiologist, surgical, medical, radiation, all these people sit down and make a plan. So then you can see, when you hear all the voices, that almost 30-35% of these plans get tweaked if people sit together and talk. So this process is not so well embedded across, and that is also a catch between the number of people we have, the resources we have, and the patient load we have. So there is a catch there. But these are things in motion, and I am very optimistic that this will happen. If I look at the sooner rather than later this will happen. Now, if I look at the palliative care situation, this is very grim in this country. So we know that almost today we lose almost half our population which is diagnosed with cancer. So this big chunk of people will need some hand-holding, some care, some empathy, and also addressing their basic needs of pain, spiritual health, sleep, that dignity and respect, even when things cannot be done in terms of curative intent. But that infra is also hugely lacking. So if I look at across the treatment paradigm, we have come a long way, but there's a lot to catch up.
Dr. Chaturvedi, we live in a country, like not just in India. Cancer is the word that is, still leads to a lot of fear and anxiousness among people. And even if it's something that it's called a deadly disease, there is still a lot of misinformation around it. It's just a quick Google search or a YouTube search, you will say, okay, do this, you will get cured of cancer. Do this, you will, even if it's an advanced stage. How we can, improve this, and how to make sure that, you have to go to the right kind of medical professional to help you.
So, this will go on till or rather, these conversations, not just for me, for across with lots of professionals, our professional bodies, doctors at large, all of us have to be accessible to the population and to be available to reply to these questions. People's worry and concerns are understandable, and this will happen. The only thing we can do from our side is that propagate what is good practice, what is best practice, and keep that strongly positioned, and be open to the answers which people will come with list of questions that I read this on Google, that on Google, and which is understandable. So I don't dismiss that. But I think more importantly, like your media and other media platforms should come out with standard websites or with knowledge that these are the authentic sites where you can go in and search. NCCN guidelines, institutional websites, AIMS, ICMR, and all these websites have treatment protocols and such things are available. So that is there. I do not see the possibility that suddenly one day we'll shut all other shops. It's not going to happen. It is just that we have to be perseverant. We have to be clear that it is our responsibility to answer these questions, and people have to get judicious. That I always talk about people that anything which cures everybody is not sure of curing anybody actually, because if they can cure everybody, then there's a catch there. Because neither talking about the type of cancer, nor the stage of cancer, nor the patient's condition, nothing is being discussed. And you say you take this or that. So everything has to be data driven. And fortunately, we are living in an era where data and tabulation and all this is possible, that we are able to get authentic material with ease. And maybe in gradually in few years we will come a day will come where people will have more recognized public domain locations where people will go out and search for information. But I'm sure even in the Western world, even in places which have developed, these things go on and nobody can stop it.
Dr. Chaturvedi, in the last couple of years, in a decade or so, we have advanced medically a lot. And we often come across like nowadays liquid biopsy, so many new advancements are there with respect to not just cancer but other diseases also. What is the status of these latest advancements in cancer oncology research in India, and what more needs to be done?
So I think till recently, or till maybe about 5-7 years, I can say that the India was not so much invested in research, except for maybe a handful of centers which were involved in research. We were more into clinical care, and that was to some extent struggling. Now I see more and more institutions are committed to research, genuine research I'm talking about, where there are partnerships happening. The government has started these innovation centers. A lot of standalone academic institutions are also looking for partners into clinical space. So these bondages are leading to actually propagation of genuine research. And this is a very, very good thing happening across. Now, if you look at the recent advancements, amazing advancements have taken place in all areas, whether I talk of diagnostic area or what evaluation or understanding tumor types or application of treatment strategies. Everything has changed a lot. Yeah, and you use the word liquid biopsy. Now, liquid biopsy is something which has rather, I would say, the version liquid biopsy 3.0 is currently what we see. It did not pick up good name because there were a lot of challenges. Like all new ideas and new technology and new practices, they take time to mature. But now it has come a long way. And now we are able to identify, or even in some ways, do a risk stratification of people who have undergone curative intent treatment by evaluating their circulating tumor cell load or ctDNA and all that from the blood sample. In certain areas where there's a recurrence of tumor, there's a doubt and you're not able to pick up properly, or in imaging, you have an area where if you take a sample, there's more possibility of having complications and less possibility of getting an yield. So you're very hesitant on intervening a person's body, but certainly you can take a blood sample, and that liquid biopsy, that blood sample, can give very precious information. So what we are seeing today, I would say, is liquid biopsy 3.0, the third phase of its journey. And in this journey, I think it is serving us quite well in a couple of areas like lung cancer, colon cancer, and a few other areas. And a lot of research is happening. So in next maybe 4 or 5 years, we'll have more authentic data and confidence that we can take bolder decisions based on liquid biopsy reports. Likewise, if I see the application of genetic assessments or mutation testing, the NGS, which we call. Now, these things are also, I would say, are maturing at a good pace. When we started with NGS testing and data, I would say hardly 2 or 3% people had treatable opportunities where a target was available and a target and a precision medical treatment was possible. Today, we have moved ahead from it. And today, it is if we are able to identify more and more people, recruit them for trials, and bring them into practice. So, I think technology application. This is only about diagnostic area, or I would say evaluation of the recurrent disease. But if you look at the application in therapeutic space, that's also amazingly evolved. You look at the operation theaters, the surgical precision has gone up, the navigation systems are able to identify which where we can cut. The precision has gone to the length of cutting at few millimeter margin and saving the bone, for example, or areas where there are vital structures the other side. We can cut and precisely get rid of a tumor without and cut down the risk of recurrence. Likewise, reconstructions have improved. The laparoscopic and robotic work has improved significantly. So wherever we, in fact, in that, I would use the word also the usage of in navigation system and robotic and lab work. We see the usage of ICG and spy camera, where we can actually do precise localization of the nodes, which can be sampled, or similar areas where you can avoid a much bigger surgery, do a smaller procedure, and have a good outcome or a safe outcome. So surgeries have improved, targeted medicines have improved. When I came into oncology, there were half handful of drugs only available in chemotherapy. Today, almost every year, 20 to 30 new drugs, new target drugs get approved. And so we have a whole bunch of things which are applicable for treatment and which are making and saving lives. For example, stage 4 lung cancer today, almost 10-12% survive 5 years. Stage 4 lung cancer. This was unbelievable, unheard of. And these are new things which are seen there. And likewise, in oral cancer and rectal cancer, every area there's been significant improvement.
As you mentioned, robotics. Like, what role has robotic surgery? What is the role that robotics can play in cancer treatment, and how much of this is available in India for the common man?
So I would say robotic has helped us improve the precision, and robotic surgery has helped in some ways in faster recovery. And so whatever is done in an open surgery is repeated in robotic surgery. Only the magnification few times higher, so it can be more precise, more accurate. For example, a nurse sparing prostatectomy is more comfortable with robotic than with lab work. Or when we do a lung surgery and all, where we can magnify the blood vessel and dissect more safely, and we can do the robotic arm can do a lot of more manipulation than a human arm. So these things are possible and they are helping in certain precise way. For example, use of firefly technique to pick up the sentinel node in endometrial cancer, low-grade endometrial cancer. These things are helping us cut down the morbidity and give better results. So robotic has space, but I would not say that for example, the access is poor for average population because the cost is higher, the equipment cost is higher, the disposable cost is higher, and so we are not able to offer at large scale. For example, at Max, here we have all our institutions have well-backed robotic program, and we are quite gung-ho about it. We want to promote it and we want to make sure that people benefit from it. But I hear what you're saying, that how much common man can access, so that is still limited. However, all government institutions are having robotic infrastructure and backup. And I think that as Indian robots will become alive, and already a couple of trials are going on, as more robots will come, the cost will go down and we'll see better results and more availability.
I would really like to take this question a bit more far. We know that in India, out of expenditure is extremely high. I mean, like what you and I can afford like, it's the likelihood of not someone else not being able to afford the same is pretty high. The question comes that we have there are some type of facilities that are available in the private sector, and then there are some that are available in the public sector. How, according to you, can we make sure that there is some kind of universality, the kind of care that everyone should deserve, irrespective of they can afford or not afford? How can this can be improved?
I would say as we keep expanding, this will happen, and a lot has happened already. I am very optimistic about it, the way I see the expansion of services in the government space and also in the private space. So imagine when more and more private hospitals open, there also the costs go down, more people can access, and more people are able to access, and that takes away the burden from the government institutions also. Also, the government schemes are very helpful. Every state is having a scheme, central government is having a scheme. Every government body, or rather, the governments are committed and are responsible to ensure that everybody gets a decent care. So this is changing. I agree, and I hear what you're saying, that there's a lot of work to be done there. But if I compare this with just 10 years back, I think we have covered a decent distance, and we are on track. And today, as I know that almost every district is going to have a medical college, and most medical college, or other, all of them will have oncology service also. For example, at Max, all our major institutions have got an oncology dedicated tower. These things are happening. Likewise, the private space is also growing at a fast pace, though still there's a demand supply gap in terms of infrastructure. And maybe if we continue at this pace in next 5-7 years, we will cover even much more ground. Only as I'm thinking, I wonder that maybe the smaller districts are still lacking, at least in northern India. The southern part, most of these smaller districts also have got infra in terms of oncology practices or infrastructure in terms of doctors and equipment and everything. But in UP, Bihar, this part of the world, the infrastructure is poor and people have to travel long distances. And this is long drawn treatment. This treatment typically takes anything from 3 months to 6-8 months. And so it's not easy for people to, if you have the infra, but still they have to be out of their work home, it's difficult for them to carry on with the treatment. So there's the challenges are there. But this is being addressed, I think.
Uh, Dr. Chakraborty, according to the cancer incidences in India, what are some of the recent trends that you have observed? Are there any specific cancer that has seen an upward trend or a downward?
Yeah. So in India, the lifetime risk of getting cancer is almost 1 in 17 or 1 in 18. That lifetime risk. Now, in the Western world, this is rather US specifically, it is about 1 in 3 and 1 in 2.5 and all that. So it's still we are protected in certain ways. Having said that, as the economy grows, as the lifestyle changes, we are also likely to catch up, unfortunately, with these numbers, and the numbers are likely to explode. So if I look at these trends, I would say it's a very worrying thing, and it is not very healthy. In fact, as more and more urbanization will happen, there also the numbers will increase. The rural India has lesser incidence, not just statistics, lesser incidence, the lifestyle, the lack of pollution, the physical activity which a rural lifestyle requires. All these things, and the food they eat, unpreserved food or the fresh food, all these things have a positive impact. And as we see urbanization, this is also, as the economy will grow, industry, all this will happen, the numbers will grow. There are certain cancers which are coming down and few of which have gone up. For example, the cervical cancer has gone down, the breast cancer has gone up, the colon cancer is going up on upward trend, gastric cancer has gone down. Certain areas, for example, G junction tumors or adenocarcinoma of the G junction, that is globally on the rise. And probably that reason is also labeled as related to diet and lifestyle. So there are certain trends of things going up and down. And but overall, the expectation that this number is going to grow, the total number is going to grow, at least in India. And the reason is urbanization, lifestyle, economic growth, and we are not able to control the lifestyle changes. If we could preserve the good part of our past and live with the modern life, nothing like it. Couple the two best parts, and then that is best we could have done. But I don't see that happening unless the civil society really wakes up and picks that as a challenge. It will not happen.
In the beginning, and you just mentioned that how much of our lifestyle is contributing to the cancer incidence. And after COVID, all of us are now more and more into sedentary lifestyle.
Yeah,
So,
and also the screen time. Screen time is
yes,
also, so we are not realizing insomnia is now the new challenge, and this is also impacting again, impact on lifestyle, impact on diet, impact everything, and leads to increased incidence of cancer. So the screen time has gone up significantly. Today, people are sleeping very late because they are glued to their phones. and TV screens. So this is a challenge. I think time has come for regulation on these fronts as well.
Okay. Uh, I just want, there are some major, there is a rise on NCTs as WHO has also, and a lot of the health experts have maintained. Could you please share for our viewers that what are some direct links of major NCDs like cancer, cardiovascular diseases, and diabetes? How these major diseases are interlinked with each other, and any word of advice for our viewers?
So fortunately, it's a very simple thing to understand. And the simple thing is that if one side is the habits of tobacco, alcohol, and I would use now insomnia and sedentary lifestyle in the same group. So this is one group which is purely habit related. And all these things have an impact on the blood circulation, and um, that impacts both the cardiovascular event, the central nervous system, the strokes, and all this also go up. And they are also causative factor for cancer, as I explained in the beginning. One is this segment. This other segment is related to our diet. And in diet, I would say the increased consumption of fat, increased consumption of heavily preserved and cooked material is also having a negative impact. Fresh fruits, vegetables, and I would say colored plate with less calories is much more healthy and protective than a, or I should a tinned material or diet which is bought online and eaten quickly and then back to work. So that is something which is really not good. And word of advice is only that follow what your grandmother was eating. I think that is the best advice one can have. And if you can have at least 60 minutes of physical activity per day, 40 to 60 minutes of physical activity per day, that will address a lot of these things. And BMI less than 25. So these are all interlinked things: diet, BMI, and your physical activity. And no tobacco. If tobacco can be banned, nothing like it. But till that happens, at least no tobacco.
Anything else that you would like to add?
So I would say one thing that unfortunately, cancer does not have unique symptoms. For example, a cardiac event, anybody can mention about chest pain, and cancer has a very subtle presentation. So even a vague symptom like abdominal discomfort or heaviness after meals, or a breast lump which is mobile, or an oral ulcer which is there for a couple of weeks, what you think may not be significant may actually be significant. So any symptom persisting for more than 2 weeks should be investigated for cancer. Unfortunately, in the body, there are only about 10, 12 symptoms, whether it's a lump, whether it's a ulcer, whether it's a bleeding from the any orifice, like a stool, blood in motion, or a cough and blood and cough, or anything, or an unexpected discharge, or a non-healing ulcer. So we have only 10, 12 symptoms. But in the behind these 10, 12 symptoms, there are thousands of diseases. So that segregation should happen, and that is only possible by being alert. So I call it what we need, maybe not screening for everything, but what we definitely need is a huge alertness level in the civil society and in the general practitioner's mind to rule out cancer at a much early stage than what we are doing right now. If I can take an example of a breast lump or an oral ulcer, all cancers in the breast or in the oral cavity will also present with an innocuous, small, mobile lump or a small ulcer, which is very superficial, no induration. One has tendency to ignore that. But if that lump or an ulcer is there for 2 or 3 weeks, please consult a clinician. If it requires, do a triple test that we call as take a sample, take a biopsy, do an imaging, just make sure that we're not missing something. And because till the time it grows, it has become fixed, it has spread to the nodes, then it is already gone to stage 2 or 3. And typically, most of the cancers take about 2 to 3 months for stage migration, from migrating from stage 1 to 2 or 2 to 3 or 3 to 4. So it's not a very big window that we have, that you sleep over symptoms for few months and then you wake up. It's already moved to next stage. So maybe 2 or 3 weeks is a cutoff period. If you have an issue, please check with your doctor.
Dr. Trivedi, thank you so much for joining us and for this wonderful discussion. I would love to connect with you again sometime. Thank you so
Yeah,
much.
thank you.